Well, good day. My name is John Michalski, and myself, along with Michael Balbesser, will be the moderator of today's presentation that will be given by Dr. Mayes, which we are very thankful for. Thank you very much, Doctor. And no problem. And what I would like to do is I would like to turn it over to Michael so he can give you the proper introduction that you deserve. Thank you.
Good day, folks. I'm Michael Bessert, patient advocate for the Scleroderma Foundation. I'd like to welcome you to the Scleroderma Foundation Michigan Chapter's web-based 2020 educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 3 years to reach more patients, caregivers, and family members who seek to obtain accurate information about scleroderma. There are individuals from all over the world that will access this webinar, emphasizing that we can be connected and sit in front of our computers, obtaining accurate educational information while staying in our homes and offices. This program is in part made possible by an unrestricted educational grant from Actilon and Boehringer Ingelheim, and we thank them for their generous support to the scleroderma community. We will focus on scleroderma, what to expect after the first 5 years. Today, our presenter is Dr. Maureen Mayes. Dr. Maureen D. Mayes served as professor of medicine at Wayne State University in Detroit. Dr. Mayes serves as member of the Scientific Advisory Board at the Argentis Pharmaceuticals, LLC. Dr. Mayes joined the University of Texas Houston Medical School faculty in 2002 and subsequently established the Scleroderma Clinic. She is currently the principal investigator of the NIH-NIAMS funded 2-stage genome-wide association study in scleroderma that has the dual objectives of identifying genes that influence disease susceptibility and severity, as well as to serve as the national resource to supply genetic material to other investigators to study this disease. Her clinical focus includes the treatment of scleroderma and its multiple complications, and Dr. Mayes continues to participate in several multi-center national trials of new agents for this disease. Her research interests include the identification of susceptible genes and disease activity genes in scleroderma and related autoimmune diseases. Dr. Mayes is the recipient of many distinctions, awards, and grants for the study and treatment of scleroderma. She is the author of over 100 published manuscripts, 19 reviews, full book chapters, and 1 full book. Dr. Mayes graduated from Eastern Virginia Medical School and was trained in internal medicine and rheumatology at the Cleveland Clinic. She received a master's in public health in epidemiology from the University of Michigan School of Health. Sorry, I practiced that word several times. Without any further ado, Dr. Mayes.
Well, thank you very much for that kind introduction. What I'm going to talk about today, as was mentioned, is what to expect in scleroderma after the first 5 years. And I want to emphasize that I'm talking here about systemic scleroderma, systemic sclerosis. So this does not apply to morphia or linear scleroderma, which is really a very different disease. And next slide. So why make a distinction at 5 years? Next. The 5-year period really starts at the onset of the disease, not necessarily at the time of diagnosis, because I'm sure, as many of you are well aware, there can be a long lag time between when you get the first symptoms and when your doctors finally figure out what's going on. But there is a reason to make that distinction, because skin involvement typically starts early. Puffy hands, tight skin, and it can worsen over the next 2 to 5 years, and then even can stabilize, not get any worse, and even can improve on its own. And so when you're doing clinical trials like I frequently do, then you want to make sure that all of your patients are in the same phase of disease, so that people who are on what we hope is an active agent versus people who are on placebo or standard of care, that will be able to make that distinction, that actually whatever medicine we're trying in the trial is working versus just the natural course of the disease. Now, the risk for severe high blood pressure, which causes kidney damage, known as scleroderma renal crisis, actually that is greatest in the first 5 years from the onset of the disease. So after that period of time, people are relatively protected from getting this sudden increase in blood pressure and severe kidney involvement. And next slide. Lung involvement, however, so skin is early, progresses first handful of years, and then stabilizes typically. High blood pressure and kidney involvement, highest risk in the first few years. But lung involvements, pulmonary fibrosis, and we're going to talk a little bit more about this later, it frequently starts in the early period, but that can continue to worsen over time. So 5 years, 10 years, it actually can continue to worsen. So it has a different course than either the kidney involvement or the skin involvement. And next. So let's talk about early small blood vessel changes in scleroderma. Next. The small blood vessel changes in the fingers can be seen in the doctor's office using a little handheld magnifying lens that has a light attached to it. And it's useful test in the early stages, within the first 5 years of disease, because sometimes seeing those changes can clue your doctor into saying, well, this really is scleroderma, it's not primary Raynaud's. It may develop into something that's more serious and that needs to be treated.
How does a doctor, if I may ask, how does the doctor determine that the difference between primary Raynaud's and scleroderma, as you mentioned?
Well, in primary Raynaud's, the skin change, the color changes on cold exposure, which is how we define Raynaud's phenomenon, that the fingertips turn pale or they turn blue and feel numb and tingly. And then when the hands warm up, when people warm up, those color changes go away and the numbness, tingling, pain sensation resolves. That's common in the general population. It's been estimated that 5% of women and 10% of women and about 5% of men will have primary Raynaud's. And we all know that that scleroderma is not at all that common in the general population. So most of the people with Raynaud's have it as primary. When you have it as secondary, as part of scleroderma or another connective tissue disease, it tends to be more severe, more frequent, and can result in ulcers or sores at the tips of the fingers.
Thank you, doctor.
And this, yeah, so I have a little handheld, which I don't have on me now, but so I can't show it to you, but this little handheld device with a light on it. And this is a photo of a normal nail of the blood vessels, tiny blood vessels, capillaries, at the nail fold. So at the top of the slide, you see the nail, and then the little clear part, that's the cuticle, and then those red things are tiny blood vessels or capillaries, and they are, thank you, yeah, they are regularly spaced, and they're all about the same diameter, and they've been described as like hairpins, bobby pins. And the point of it being in looking at the nail folds is that that is one area of the body where the blood vessels in the skin, instead of being perpendicular to the skin, so if these are the blood vessels, the skin would be like that, but at the nail fold, the blood vessels become parallel to the skin surface, so you can visualize them more easily. And the next slide. And this is a finger, and you can see, if you could, John, move your cursor, right. Yeah, so you can even see with the naked eye without much of the way of magnification that those are more prominent. Those look dilated. And the next slide. And this is a magnification of that. And you can see that we've got dilated and tortuous, curvy, winding capillaries. And some of them, especially in the left-hand side of the slide, there's that period, there's that area where there are no capillaries. And they've dropped out.
Let me just go back to make sure people understand. So we'll just compare the two slides that we just looked at. So you see those, and then we see that.
Right. Now the magnification is a little different in both slides. I couldn't find one that was exactly comparable, but I think that this is what the doctor is looking for. If they see changes, something like that, then it's clear that it's not primary Raynaud's, because in primary Raynaud's, the capillaries ought to look pretty normal. Okay, in the next slide. So what is Raynaud's? Because a lot of times people will think that Raynaud's is digital ulcers, but really it's just the description of color changes of the fingers on cold exposure. And sometimes if people get nervous or anxious, they'll get an episode of Raynaud's as well. So the next slide. Usually it's the first sign or symptom of scleroderma, not always, but frequently it's the thing that clues your doctor into thinking maybe something's going on here. And next. Now this is, you can see October 20th, 2009. It actually is a photo that one of my patients took. Yes, and you can see one finger is very pale, and two fingers are pretty normal. Yes, and the index finger is purple at the tip. And that purple discoloration can be fairly subtle, at least if you take a photo of it. But if you look at it in real life, the purple is frequently very prominent. And some people will say that their hands turn black, which they really mean dark purple, because of the the decrease in blood supply. You can tell that this was taken by somebody at home because you can see the computer keyboard in the background. But anyway, it's one of the best slides I have of actual Raynaud's phenomenon occurring in one of my patients. And the next slide.
Before we leave that, doctor, I want to ask the question. I know this, my wife had this occur a few different times, not to this whiteness of the degree, but how does a patient go, once this has occurred, how do they warm their hands back up? What is the best method for them to be able to get the blood flow started again?
Well, the best thing to do, I think, is to keep the central body warm. So wear an undershirt, and one of my patients, actually from Michigan, would get these very thin, lightweight, but effective silk undershirts that could be worn under a regular blouse that wouldn't show really. And she said that would keep her very warm, or a vest or an extra sweater, because it's the central body core temperature regulates the blood flow to the extremities. And this is a process that's for, that developed probably over eons in order to maintain central body temperature, so good temperature in the lungs, heart, and brain. You would sacrifice blood flow to the extremities. And this is an exaggeration. This is an exaggeration of a natural response.
So, like I said, I have seen that. I did see this with my late wife, Eileen, and that's why I asked this, because I know we had the issue of trying to warm her up after the fact occurred.
Yes, well, once it starts, putting the hands under warm water, if you've got, if you can easily get warm water available. These days, most of my patients will carry hand warmers, these chemical hand warmers in their pockets that can be activated in various ways. And there are now gloves if you have to go outside. And I know in Michigan in the winter, you can't avoid, unless you want to hang out in your house for several months at a time, you can't avoid that kind of cold exposure. So they've got gloves that have battery operated warmers. all kinds of things that can be helpful. Michael, have you found anything that's been helpful for you?
I have it also in the feet, and
Yes.
I have electric socks, electric gloves, hand warmers, layered, all that. And we've been very lucky. We've had a mild winter, but it's I have found if I've ever gotten any type of a vaccination, like the flu shot, most recently was the first of the Shingrix, and
Yeah.
I got a cold chill from the just the air, which put me into a Raynaud's attack, but then me putting into uncontrollable shaking. But as said, also one of the triggers of Raynaud's is stress. And as I've told fellow scleroderma warriors, we can use that to our advantage. And everybody looks at me like, how can you use that? And I said, if you're in a conversation, possibly political, like this days, and you look at your hands, that's a trigger or a barometer that you're stressed. And if that happens, I politely excuse myself from the conversation and walk away, because stress does it too, very
Yeah.
much as cold in me. So
Yeah.
Well, thank you, Doctor.
Okay, now we're going to talk about digital ulcers as a complication of scleroderma, and this is one of those complications that unfortunately can occur in the first year of disease, the 5th year, the 10th year, and beyond. And next. Over time, ulcers will occur in maybe 40 to 50% of scleroderma patients, so that means that about half of scleroderma patients will not get it, and even in spite of years and years of disease, may never get it. Next. And they're caused by poor blood supply, not by infection, although they can become secondarily infected, just like any open wound that you have that's present for weeks and sometimes months can get infected. Not all ulcers need to be treated with antibiotics. If they start to drain, if there's a lot of redness or swelling around them, then yes, those are indications that they may need to be treated with antibiotics. But usually from the time they first occur, the approach from a medical point of view is to try to improve the blood supply as much as possible. And that's with various types of medicines. The most common ones are calcium channel blockers, nifedipine, procardia, amlodipine. There are several of them. And other medications that sometimes are used for another condition called pulmonary hypertension. They can improve the circulation. And I'm now doing a clinical trial of an IV drug that may be helpful, but we'll wait probably another year to see if that gets approved and if we can show that it's effective. It's a multi-center trial. They're recruiting 180 patients throughout the country, and we're only doing it in the cold weather. So we've got somewhere between a third and half of the patients enrolled, and we'll probably have to wait until next fall to continue enrollment. But nonetheless, there are medications out there that can be helpful. Unfortunately, not everybody responds to even the best medical care, and it just takes, weeks or months for them to finally heal. Next. This is what I just said. The usual treatment, medicines to improve the blood supply, and then the lifestyle changes we were also talking about, gloves, hand warmers. And this is unfortunately one of the complications that continues over time. It's not confined to the first 5 years or 10 years. It can happen over and over again. Next. So GI problems. I wanted to talk about that next. They can start early, particularly reflux. Heartburn, but it's more than the usual heartburn. If everybody eats food.
Doctor, if I might just ask you, maybe you just a little bit away from your microphone. It seems to be garbling a little bit on your computer.
Okay. Well, I'm not sure. Well, let's see. I'm not sure where the microphone is, but is that any better?
Michael, are you hearing the same static?
Yeah, I did, and I thought it was I'm on 2G rather than my 5, and I thought it was my end of the connection, but
Okay, well, like I said, we just have a little bit of a background static, so it wasn't there originally. That's why I said, I'll let you continue. Thank you, doctor. I'm sorry.
Oh, no, quite all right. And we were talking about the usual reflux or heartburn that people get by eating spicy foods or eating late at night, but it's not every day. It's not multiple times a day. It doesn't interfere with eating. But the kinds of reflux and heartburn that scleroderma patients get tends typically to be every day and several times a day. So this complication doesn't affect everybody. Some people have very mild heartburn, easily controlled, and other people have more severe problems. And next. Now, the treatment includes a medication to decrease stomach acid, and other medicines can improve the mobility in the stomach and bowels, less complicate the esophagus. Usually, medicines are proton pump inhibitors, and these are omeprazole, Nexium, esomeprazole. I don't want to leave out any, but now there's. Okay, we're talking about just to decrease stomach acid. Medication is called proton pump inhibitors. There are several of them on the market. Now, proton pump inhibitors have gotten a bad rep lately because they can also interfere with absorption of different medicines in the stomach. Sometimes calcium is part of the problem. Some gastroenterologists will say, if that's the case, don't be on it every day. Don't be on it for more than 6 weeks or months at a time. Unfortunately, scleroderma patients are not the usual patients. Scleroderma is an exception to the general rule. The potential complications of scleroderma in terms of GI involvement are that it can cause ulcers in the esophagus, scar tissue can worsen in the esophagus with the ulcers and even get a stricture. So I think scleroderma patients should actually continue to take their proton pump inhibitors on a regular basis. My patients take 2 or 3 times the usual recommended daily dose. We can also alternate, say, take proton pump inhibitors and evening take another kind of medication called intact memory, aridity, Now let's talk about treatment again and review it. Usually the treatment includes medicine that decreases stomach acid. And these are called proton pump inhibitors. There's a whole family of them, now 6 or 7 on the market. And that can be very helpful. The proton pump inhibitors lately have been given a bad rep because there's concern that if the acid in the stomach is decreased for an extended period of time, like months, that it can interfere with absorption of some vitamins and minerals, things like calcium. That's true, and in general, you should only take medications for as long as you need them. But scleroderma patients are a special part of patients, special part of patient care. I think patients understand that, and sometimes physicians are less understanding if they don't deal with a lot of people with scleroderma. One of the side effects of having a lot of acid or recurrent reflux is that you can get ulcers in the esophagus and sometimes scar tissue that causes a stricture, so it makes it difficult to swallow. And because of these complications, I think it's worthwhile. The benefit outweighs the risk. And you can be checked for levels of calcium and vitamins in the blood to make sure that you are getting enough and your vitamin levels are normal. There's other medications that are helpful to improve the motility in the stomach and bowels, because sometimes the decrease in motility is not just in the esophagus, not just heartburn, but it also involves the stomach, that it doesn't empty and people take a few bites and then feel like they're full because the normal motility in the stomach that clears things out of the stomach into the bowel, that is delayed. And these medicines, the pro-motility agents, there are now 2 on the market in the US. There's some difficulty and there's some potential side effects like with most medicines, but I think if you need them, it's worthwhile and it's worth the risk, and you can be checked to make sure that you don't have any of the complications. But one of the things I tell my patients over and over again, the most important thing is lifestyle changes. Elevate the head of the bed, not just on pillows and not just with having an adjustable bed, because those sorts of things tend to crease people in the middle at the waist, and that's not going to be helpful for reflux. So getting blocks, 4-inch blocks, put them under the head of the bed. So the entire bed is on a slant. That can be very helpful. I do have a few patients who say that they sleep in a recliner because that's the only way they can keep things, normal stomach acid, normal stomach juices, from going back into the esophagus and causing reflux. Another reason to control the reflux is that if you breathe a little bit of that acid or a little bit of those stomach secretions at night, if they come up into the throat and you breathe them in, it can damage the lungs. So it's not just a matter of comfort, it's really a matter of your health.
What doctor should a patient go to have this looked at?
Well, a gastroenterologist usually. And fortunately here at the University of Texas, we have a team of people who see a lot of my scleroderma patients. There's myself and 3 other rheumatologists, a pulmonary specialist, and a GI specialist. And the pulmonary doctor and the gastroenterologist, see a lot of my scleroderma patients. So they've become very familiar with the kinds of problems that scleroderma patients have. And I know that's not available to everybody, but most doctors want to take care of their patients well. And if the patient has to be their own advocate, unfortunately, and as usual, to tell the doctors that perhaps with their scleroderma, they should look at motility problems and be treated if it looks like they really are having problems with decreased motility.
So really one more doctor, one more type of doctor in the team of doctors to be treating the scleroderma patient.
That's right. That's right.
Interestingly enough, and this is my story and everybody's unique, but mine was caught in a routine colonoscopy. My surgeon that did the colonoscopy, we're a small town, family friend and the whole deal. He noticed that I had Prilosec as a possible, I was allergic to it on my chart. He said, "What's up with that?" And I said, "I've had a lot of GERD symptoms or, whatever." And he goes, "Well, as long as I'm going to have you out, I'm going to do an endoscopy." And I'm glad he did, because that's when I was diagnosed with Barrett's esophagus.
Oh, yeah.
Really started my journey towards the scleroderma diagnosis. So yes, it's a lot of interesting events that can happen and just how it unfolds. So.
Well, thank you, doctor.
Okay, and next. So let's talk about skin involvement. Skin is characterized by thickened, inflexible skin that is hide-bound, which is to say, let's see if you can see, so this is called tenting of the skin on the back of the hand, so you can pull the skin up. But in scleroderma, if it involves the back of the hands as well as the fingers, sometimes that flexibility is decreased and you can no longer tent it. It almost always starts in the fingers and goes to the back of the hands. And in some people, it stops there, never gets any worse, just involves the hands, maybe a little on the face, but nothing else. But in other individuals, it also involves the forearms, the upper arms, the trunk, the legs. And there are people with all combinations in between these two extremes. I do skin scores on people which measures skin thickness in 17 body areas, and it goes from 0, which is normal, 1 mild, 2 moderate, 3 severe, and so that a perfect score, which on the bad side is 51, and a low score will be 2 or 3. If people just have a little bit of puffiness or thick skin of the fingers, 1 on each side, that's 2, and nothing more, and they don't get anything more. It's one of the mysteries of scleroderma, the many medical mysteries. What distinguishes somebody who has limited skin involvement from somebody who has more severe and progressive skin involvements? And the reason that we make that distinction is that people with skin involvement that's mild also tend to have mild internal organ involvements. And people with more severe or extensive skin involvement are at higher risk for getting internal organ involvement that may be progressive as well. But notice that I say a low risk or a high risk because nothing in this disease, and as Michael mentioned, every patient is unique. You can't say, oh, you have limited skin involvement, go away, you're going to be fine, you'll never get internal organ and disease. That unfortunately is not the case, and we need to be vigilant and keep doing monitoring tests, screening tests, to find out if people do have internal organ disease. Is it severe? Is it progressive? If it's getting worse, then we're going to treat it. If it's mild, stable, then there's no need to treat. And next. Yes. So, and that's just what I mentioned. The extent of skin involvement, usually the maximum skin involvement is there within that first 2 to 5 years. After that, the skin doesn't get any worse. And next. The skin can stabilize so that the skin score may go up to 20. And the next time I see the patient in 3 to 6 months, it's still 20. And the next time it's 18. And the next time it's slowly going down. And only on very rare occasions, so I hate to say 100%, does the skin reactivate after years of improvement. Over time, I think I've seen, beginning when I was at Wayne State and really focusing on scleroderma, probably close to 3,000 scleroderma patients. And I have seen fewer than a handful of patients, fewer than 5 offhand, that were fine for a period of 10, 15 years and then worsened again. So once the skin starts to stabilize and improve, that's for most people, by far the majority, that's really going to be it in terms of skin, not necessarily it in terms of other problems, but it in terms of skin. And next. One of the problems though, even though the skin can loosen up, the skin score can start to go down. The loss of motion in the fingers, so that the fingers are flexed, that tends not to reverse. So we very much need better treatments. We very much need to be able to identify people who are going to develop these contractures, find them at least at this point, and fix it so that it either improves back to normal or doesn't go from mild contractures to more severe and functionally impaired hand involvements.
So is that physical therapy at that point?
Physical therapy can be helpful, but the underlying progress, the underlying progression may not change. I think physical therapy can be helpful once it starts to keep it from getting worse or to help slow down the progression of worsening of the finger contractures. But it seldom is the case when the contractures go back to normal. And next. Let's talk about the lung in scleroderma, because we now have a medicine that's approved for the treatment, although there are some problems, and we'll mention that briefly. So what is lung involvement? There are 2 types. Pulmonary fibrosis, which is increased scar tissue or collection of collagen in the lungs. And as this collection of collagen accumulates in the lungs, it replaces the tiny air sacs. And those tiny air sacs is where the real function of the lungs occur, because you exchange oxygen to carbon dioxide, and you've got millions of these little air sacs. They're microscopic. But so if you start to lose a few or 100 or a few thousand, over time, people get short of breath because they just don't have the efficiency in the lungs. And the other kind of lung involvement is called pulmonary arterial hypertension, PAH. It damages the small blood vessels in the lungs. So the bottom line is the same. The exchange of carbon dioxide and oxygen are impaired, but there are two different mechanisms. And actually, there are two different types of medicine that can be helpful for each of these. So it's important for a doctor to make that distinction. And next. So pulmonary fibrosis, also called interstitial lung disease, and it's abbreviated as ILD. Next. It can start in the first 5 years, but it typically worsens in some people. And like I mentioned, everyone's different, everyone is unique. Not everybody gets this. But what I do for my patients, and I think what many people do, physicians, rheumatologists, and pulmonologists who are used to seeing scleroderma patients, we need routine tests to monitor for this complication. And usually that's done with pulmonary function tests, with something called a diffusing capacity, DLCO. And this test is where you breathe into the machine and it measures the flow of oxygen, it measures the amount you can breathe in and breathe out at a particular time, and it measures the diffusing capacity, measures the efficiency of exchange of carbon dioxide and oxygen. If the pulmonary function tests are abnormal, or if they seem to be worsening, then it's important to do a CAT scan of the lungs. A plain chest film is not very sensitive. Plain chest films are great for pneumonia or lung masses or other things, but in terms of early fibrosis, which is the point at which you want to be identified and the point at which you want to start treatment, early fibrosis is best identified with a CAT scan, because CAT scans are x-rays, there's some radiation involved. You don't want to do a CAT scan on an annual basis. You do pulmonary function tests. And I only recommend a CAT scan if the pulmonary function tests are abnormal. And next. Now, I didn't find a plain x-ray that showed that was normal. So here is an x-ray, plain film of someone with interstitial lung disease. And if you're not used to looking at x-rays, you look at this and you won't know what you're seeing. Mm-hmm. But if you look at the very top of the lungs, it looks dark. Yeah, good, thank you. And then as you go down further and further, you see this sort of white smudgy stuff. That shouldn't be there. Air on an x-ray is invisible. Air on an x-ray should be dark. And if it's not dark, then you've got something that's in the lungs that shouldn't be there. And in this particular case, it is interstitial lung disease, which in scleroderma tends to start at the bottom of the lungs and then slowly progress up the lungs. Some people will have a little bit in the bottom of the lungs, and 5 years later, it's still there, a little bit in the bottom of the lungs, and 10 years, it just doesn't change. And those people I tend not to treat. They're stable. They're not going to require oxygen at any point years or years later. So not everybody will develop, not all scleroderma patients with ILD will have it be progressive. So you have to be very careful. And next. So if you do a CAT scan of the lungs, and again, the big white glob in the middle, that's the heart. And the white glob at the bottom of the screen, that's the bones, the vertebrae, the ribs. And you can see that a lot of dark areas, that's normal lungs, but then you see a lot of those white areas. Those white areas shouldn't be there. That is fibrotic tissue that has replaced the lungs and interferes with breathing. And this would be considered significant fibrosis on a CAT scan of the lungs. And this sort of thing would require treatment. And next. So why monitor for ILD and scleroderma? Well, because we've got treatment for it. There are now medications that can slow the progression of lung fibrosis, so you want to catch it early. And there are several ongoing clinical trials of both new medications that are designed to decrease fibrosis, or repurposed medications that may be successful in scleroderma interstitial lung disease. Did I mention them? Let's see. And next. Before we get to pulmonary hypertension, let me talk a little bit about those medications. The first one we used was cyclophosphamide, also known as Cytoxan, which sounds terrible, and in some ways it is. It was originally developed to treat cancer, and it still is used a lot to treat cancer. It's very effective. But as you can imagine, it does have potentially serious side effects. We use lower doses than in cancer, so not quite as severe as all the side effects that people know about chemo. But there's another medication called mycophenolate, which was found in more than one clinical trial to be effective. And that has become, to a large extent, standard of care in scleroderma patients. And then there is the most recent one, which is called nintedanib, also brand name OFEV, O-F-E-V, and I don't want to recommend one treatment over the other or to say that these treatments are absolutely wonderful. They are not curative. They can slow down the progression of the disease, but we still need more treatments, and all of them have potentially serious side effects. So it requires a discussion between you and your doctor to see if it's worth it, if you can tolerate the medication, and if it's just right for you or not right for you. But I remember when I started out in this business many years ago in Detroit at Wayne State, we had nothing.
That's right.
And cyclophosphamide, Cytoxan, was the first drug we tried, and it was fabulous that we had a positive response, but as I say, the bad news is that it was Cytoxan. Okay, and next. So let's talk about the other kind of pulmonary involvement, pulmonary arterial hypertension, known as PAH. Next. So it's caused by damage to small blood vessels, and so with those, when you lose those small blood vessels, in some ways it's very similar to the photo that I showed of the NAILFOLD capillaroscopy in the scleroderma patient, where you had these points along the nail where there was no capillaries, where there should have been, there were before, and they dropped out. Well, that's the same thing going on in the lungs. And Raynaud's happens in 95% of scleroderma patients, but pulmonary arterial hypertension is only 10 to 15%, even after years and years of disease. And that's, again, one of those many unknowns. If everybody has small blood vessel disease in scleroderma because they have Raynaud's, why doesn't everybody get pulmonary PAH? Well, it's fortunately, not everyone does. 85, 90% of people will not. But those 10 to 15% who do are very seriously affected. And this is a complication that occurs usually after years of disease. And next. The symptoms are similar to interstitial lung disease, which is pretty much shortness of breath on exertion. One of my patients said to me that he couldn't pinpoint exactly what was wrong, but when he went with his fellow coworkers to lunch, he used to be able to walk with them and talk at the same time. Now he could either walk or talk. He couldn't do both, and they were walking faster. He told them to slow down, and they didn't think they were walking any faster than usual. It was his ability to breathe that had changed. And next. And this is one of the few complications that typically occurs years, sometimes decades after the onset of disease. So it's something that really needs to be monitored essentially forever. And next. This is the 10 to 15% of patients. And next. Monitoring for PAH. So what do you do if you suspect somebody's short of breath? Well, pulmonary function tests can give you a clue, because the part of it, the first part, the spirometry, the vital capacity is fine, but the diffusing capacity, the DLCO, is low and out of proportion to the rest of the breathing test. And next. So if you suspect it's there, what do you do? An echocardiogram. This is an ultrasound of the heart that can look at the pulmonary artery to see if it's abnormal or if the right side of the heart. Now, this is not the usual left heart failure, congestive heart failure, complications of hypertension. This is something that occurs on the right side of the heart. The part that takes the blood from the body goes into the lungs, exchanges carbon dioxide, and then the blood that's oxygenated then goes to the left side of the heart and gets pumped to the rest of the body. And next. Then if these tests are abnormal and it's a pattern that looks like, could be PAH, the only way to really diagnose it is with a right heart cath. There's no non-invasive way to find out if PAH is really there. It's the only reliable way to diagnose it. And this actually measures the pressure in the pulmonary artery, the pressure on the right side of the heart. And next. So why bother to monitor? Well, in the old days, again, 30 years ago, I didn't do echoes on a regular basis because we had no medication to treat it. So if you found it, there was really nothing to do about it. But now we have multiple medications. There must be a dozen now that can slow down or stop the progression of PAH. And these have been life-saving for many people.
Before we leave this slide, Doctor, where would I'm familiar with the 6-minute hall walk. Where does that fit in?
Yeah, that's very good. That is a key combination, the pulmonary function test and the 6-minute walk test. And the 6-minute walk test is actually as simple as it sounds. People are told to walk down a corridor for 6 minutes, and usually the corridor is measured so that you can have, you know exactly how many yards or how many meters somebody has walked. And at the same time, they have an oximeter that will measure the oxygen saturation in the blood. And one of the problems with doing 6-minute walk tests and oximetry measurements on scleroderma patients is that if you put it on the finger, which is typically where it's done, and somebody has puffy hands, thick, tight skin, and a Raynaud'S attack, then the oxygen sensing machine, the oximeter, will say, oh, you know, bells and whistles will go off, and they'll say the oxygen is really low. So what I do in my pulmonary function lab is have people use either an ear oximeter or a forehead oximeter, which can be sort of taped on with a Band-Aid kind of thing, so that the Raynaud'S and skin thickness is not, does not interfere with the measurement. One thing I found is a little tidbit, and I think I learned this on the Scleroderma Foundation website, and a patient suggested that if you were doing this and you have the thick skin of the fingers, to do it, to have them put the little sensor in the web space between the thumb and the finger, because usually that's pretty pliable skin, and it will pick up oxygen. So I think if pulmonary function lab has not invested in the little ear clips or the forehead oximeter, they can try putting it here and see if they can get an accurate reading on that.
Thank you, Doctor.
Okay, so in summary, long-term outcomes in systemic sclerosis. We've not gone over all the possible complications because there are some more rare ones. We've only really talked about the most common ones and the ones that should be monitored for. And next. Well, over the past 30 years of seeing some 3,000 scleroderma patients, I've seen tremendous advances in treating not just symptoms and improving quality of life, but in prolonging survival. And next. Considering many new drugs in clinical trials that are currently being tested, I have great hope for the future. Actually, these days we've got, there are pharmaceutical companies that are coming to me and saying, do you want to participate in this trial? And at this point, I've had to turn some down because we simply don't have the research staff or the number of patients who can be in new trials, because I've got a lot of people in these currently ongoing trials. And actually, that's a good thing, that we've got a lot of interest on the basis of the NIH, on the basis of pharmaceutical companies, to try to find medicines for this disease that can be effective, that can be safe, and readily prescribed. And thank you for your attention. I think that's all.
Well, Doctor, I want to say it is very encouraging that where we sit here talking about scleroderma after the first 5 years, because we know back in the 90s, many times our patients were given a life sentence saying you only had 3 to 5 years to live.
Right.
And so from that standpoint, the encouragement in the trials and the medication, plus understanding the disease, I think should give encouragement. And I'll just speak from my experience. Like I said, my late wife, but she died from the complications, but she lived with the disease for over 20 years.
Yeah.
So, I mean, you know, we met after she had it and we married. And so from that standpoint, just to let people know, it's not a life sentence. It's something that you change your life to live with, and it doesn't mean that your life's over. So you can have a good life. And I want to say thank you again. And Michael, would you like to add anything?
Well, yeah, before I do the closing, I just wanted to say I was technically diagnosed in 2013.
Mm-hmm.
I think I was symptomatic as far back as 2011, and I was diffuse. Obviously, I said Barrett's. My GERD was my first issue, then the Raynaud'S, then the shortness of breath. So it just kind of fell right down the progression. I had slow motility. I mean, IBS. I mean, I got the whole gambit. And here, so fast forward this few years later, the treatment I chose was CellCept. I was given the choice of the chemotherapy direct infusions, and my wife's a 17-year cancer survivor. I said, no, I'll go this route.
Yeah.
Which I did, and I have been on 2,000 milligrams of CellCept up until November of last year, when Dr. Dinesh Khanna is my rheumatologist, so very blessed there. And he said something about, you know, high fives because you're in remission. You know, you're doing great. Are there any concerns you may have? And I said, well, a couple. And he said, what's that? And I said, I got skin tabs. I've got barnacles. I think they call them senile warts. Everything is growing a lot faster than it should be. So apparently that is a possible side effect of CellCept. So now I'm back down to 1,000 milligrams. But like I said, I'm past the 5-year mark. One thing about patients with scleroderma, when we have reached that 5-year mark, we run into a couple obstacles. As like I said, I'm a peer mentor, is do we wait for the other shoe to fall, which is a possibility, as was said here. Things can develop over time, but you also have survivor's guilt, which I've run into people when I went to the 2017 Scleroderma Convention in Phoenix. My health vastly improved when I saw the same people at the 2019 conference in Chicago, and everybody said, you're a different person. And it was great to hear because the treatment has worked for me. I follow the doctors. My positive attitude has worked for me, but it also gave me survivor's guilt in a way. But this was a very educational. And like I said, as a patient advocate, I do this for the foundation because I am blessed. I can do this where other people can't, and I'm paying it forward. So I appreciate your taking your time out of a busy schedule to do this.
So Michael, why don't you wrap this up with your closing dialogue?
All righty. So thank you so much, Dr. Mayes, for presenting today for the Scleroderma Foundation. I know this information has been beneficial for all of us. Thank you for helping to educate the scleroderma community, and thank you all for everything you do for our scleroderma community and the foundation. Staying educated about your disease or the diseases that affect the life of your loved ones, you help and become more effective in healthcare advocates. If you have questions about anything that has been presented on this webinar, it is best to bring them to your medical team, as they know your specific medical needs and can help you make the right decisions. Thank you again for viewing this webinar. Muchly appreciated.
Okay, take care. Thank you.
Thank you very much.